really is the point of my brief presentation here tonight. And one of the things that we talk an awful lot about is the PPD, right? The nursing hours per patient day, right? And when I came into office in January of 2018, we often hear some nostalgia for management companies and, maybe we need another management company. But what I came into office with was a PPD of 2.93. So as you can see, as soon as we get here, the PPD had already pre-pandemic fallen under 3. So we immediately identified this as a problem. And the reason we know about the information that I'm about to impart is because County Council, through its Human Services Committee, did such a great job of oversight over the last 4+ years. So we have gone through all of the YouTube videos, thank you, of the meetings, and we have created a compendium of those meetings, which we are going to publish one of these days when Sue edits the compendium, so that everyone can see how thoroughly County Council and its Human Services Committee has studied the issue of Graysdale, how insightful and incisive the questions that the Human Services Committee has asked of the Graysdale administration, and how much oversight and how much County Council's learned about Graysdale through. So when we publish this compendium, it'll be on the internet. We'll give you copies of it. I'm going to get it bound, and it is very interesting. And it does, one of the things it does prove is that the Human Services Committee over 4+ years now has done a ton of work. But anyway, so I get here and the PPD is already under 3, 2.93. It's, while we're still with Premier Management, before we disengaged with Premier, it's 2.9. It's 2.9. I'm getting these numbers from Human Services Committee meetings. It's 2.96. We're starting to get it to a place where, because of our management, we're starting to get it to a place where we think it's a little safer for our residents. 2.97, it's moving up. We're still at a budgeted 3.2. We hired the current director of nursing. It's still at 2.8, 2.9. And then we get up to 3.45. This is pre-pandemic. We had a 3.45 PPD. Then it was 3.41. The previous year it was 2.91. Then we had it at 3.41. And then we had it at 3.4. That was 0.2 over budgeted. We had 3.2 budgeted PPD at the time. And then the pandemic struck, and we still had 3.28. We kept it up there, but unfortunately, COVID, we were at 3.25, 3.37. So as you can see, pre-COVID, we had a PPD that we inherited under 3, and we had it in the mid-3s. So COVID, to circle back to my COVID changed everything. And now, thanks to your help in approving our plan, we're going to try and get back to that 3.4. And I'm really happy to report to you recently, on May 22nd, it was 2.27, so low, too low, right? The 23rd, 2.79. The 24th, 2.83. The 25th, 2.78. The 26th, 2.64. 27th, 2.58. And on the 28th, we hit 2.85. On the 29th, it dropped down again to 2.84. But the day after, it went up to 2.94. We're on our way back to 3. It's been a struggle. Part of the reason our PPD is on its way to 3 now is because of the agency that we're bringing in, which is why it was so important that we asked you for that additional agency money. But we believe when we fully are able to implement the plan that you approved at your last meeting, we're going to be able to get to the mid-3s. Thank you very much.
Yeah. I guess we'll go right into any other courtesy of the floor, I'm sorry. None? Okay. Let's go into the update from Graysdale's director of, nursing, but Jen,
Well, I'll just go over the sheet that I gave you.
All right.
So you can just see what our figures were in April. So you can see our census was 416. Again, we were on our way to get down to 400. That's where we wanted to be at. Open beds were 272. We had 339 referrals. We still have 60-plus people on our wait list. We had 13 people discharge. The average PPD for April was 2.6. Again, you saw it increase from the month before. With COVID, we had 3 residents and approximately 8 staff during the month who had got COVID. Current cases right now, I have 4 staff members. I did just have 2 pop, so it says 2, but there is actually 4. Our vaccine rates with staff is 100%, and with our residents are 94%. Right now, there is a new initiative coming down from CDC that all healthcare personnel 50 and older should be boosted. It's going to count as your full series with 1 booster. So we are working on that. The Department of Health announced during this month that several waivers will be canceled. One of that being the temporary nurses aid program, which we've already begun. We had our people through the program anyway. And then we are planning, preparing for the Department of Health annual survey. So that's pretty much all I have. And I just want to introduce Dawn if anybody doesn't have any questions.
Let me stop for a second. Does anyone have any questions for Jeff? Go ahead.
Yeah, I was going to ask about the waivers, so thank you for that. And also, so the wait list of 60, how urgent is their wait? Or is that, it seems like the wait list is growing, which is a nice thing for when you're ready to be able to admit again.
And these are people who actually did the applications. There's a bunch more that are just waiting once the bed's open, and they'll come in and do the paperwork. But Mike Colon gets tons of phone calls every day just to verify if the beds are open yet. So with this increase in the PPD, we can start looking to maintain that 400.
And is that, are they coming from home? Are they coming from other facilities?
Other facilities, home, everywhere. We have quite a few from other facilities that are waiting.
And you can't exclude them from choosing to not be vaccinated, correct?
Correct.
That's a staff requirement only, not a resident.
Correct. We can encourage.
Yes, thank you.
Are there any other questions? While you're here, and I've spoken to Michael, and yeah, I know there are people, it's not like people don't want to come in. So we have people that'll come in, and it's staffing is the issue. So, and we just started, so I'm not going to go back over what Ms. McClure spoke about today going forward. How are we looking? I mean, it's not like what you've done, we did at the last meeting, probably had some big impact right out of the gate. But do you have news that you're getting applicants at least, or resumes? Or?
Yes. So we do see an uptick in them. With this booster thing that they announced, hopefully that does not affect us. There's some issues because some may see it as ageism, because you're saying 50-year-olds have to get this booster and nobody else does. And how do we track that? So there's different things going on between the Department of Health and CDC.
But staff-wise, you're saying that you've seen an uptick in interest. And I believe from day one, it's been the ratio. In other words, if we can get more staff, we can get to that point and start admitting. We can get more people in beds. It's all connected.
Correct.
So right now, the key is we need staff, because based on my conversations, it would appear we're on a good track, I'll say, a good track with filling beds. It's really about staff, and that's
Correct.
our main focus right now.
Correct.
All right.
I have one more question.
Go
I
ahead.
apologize.
No, go ahead. Miss.
Regarding the Department of Health, and I know they were at a point where they were taking written statements or requests. You've written to request that they reconsider the 4.1.
Yes.
Where are they in that process? It was what, the 3rd round or something?
Yes, they're still deciding what to do. My belief is that they're waiting to see what CMS decides.
So there's no other further movement at this time?
No.
Okay, thanks.
All right, thank you very much.
Well, let me introduce Dawn and what she's going to do.
Certainly.
So my goal as the administrator is to get Graysdale back to 688 filled beds. Years ago, we had a low census of around 534, and we were able in a short time to increase it to 670. And I was the admissions coordinator at the time. So through our strategic planning, in lowering our census numbers to 400, we were already anticipating any future changes that either the Department of Health or the Centers for Medicare, Medicaid would make regarding all nursing homes. We are optimistic in thinking that we will be grandfathered in on any changes that they may decide to enact. We must be prudent planners with Graysdale's future for the residents that reside within Northampton County, that one day they will need to call Graysdale home. So now I'm going to bring up Dawn here to review the position control, because that's the key to everything, all our positions that we have in the nursing department. So when Dawn began her career at Graysdale, one of the first items that she took on was correcting this position control. It was a huge undertaking. As a matter of fact, I think when we first came in here, that was one of those words we kept talking about. So I'm going to let her tell you about the problems and the process that she endeavored to make position control for the first time in a long time accurate. I'll let her come up.
Okay. Hello. Jen's going to hand out my PowerPoint presentation. So we are presenting this to County Council. It is the current state of affairs at Graysdale. We have a current census of 400. We have the original bed capacity of 688. And the bed capacity, once we go with the daycare on Southeast 1, will be 661. With that being said, we can absorb the beds, the other beds, if we need to. On page 3, the current breakdown of beds. So on the left-hand column, it has each one of our units. On the top rows, top going across, we have, it'll tell you how many one-bedded rooms, two-bedded rooms, three-bedded rooms, and four-bedded rooms we have. So for example, Northeast 1 has 11 one-bedded rooms currently, 8 two-bedded rooms, no three-bedded rooms, and 1 four-bedded rooms, for a total of a 31 census. I'll go down to the towers because they are all exactly the same. So each tower has 2 private rooms. They have no 2 and 3 beds, and all of the rest of the beds are 4-bedded rooms. So that is a census of 50 for all of the towers. That would equate to the 688. On page 4, as Jen said, upon my arrival, there was no position control for the nursing department. I did have some questions. You know, how many people do I need? How many RNs? How many LPNs? Part-time, full-time? And that was not in place. So we had what we call a position book, and that contained a posting form. A posting form is just a document that denotes the exact schedule of each position. The posting form is posted on a wall for all the staff to bid on. We post it for 2 weeks, according to our collective bargaining unit, and the jobs are all awarded by seniority. The project of rectifying the nursing department position control took about 8 months. Many staff were in a staff float or a relief org, which means that they had no home and they would just float every day. Every morning near my supervisor's office, there would be about 30 people standing around waiting for their assignments. This time-consuming process brought to light numerous issues. There was no continuity of care for our residents. There was no consistency for the staff to develop relationships with coworkers or with residents on any of the units. It was difficult to place everybody. We had to do it by seniority, but we also tried to do it by preference. To solidify an accurate position control, we had put in place a suggested staffing template that denotes exactly how many full-time, part-time RNs, full-time, part-time LPNs, full-time, part-time CNAs were needed for each unit, each day, each shift. So we now have that in place. Once we had that, we began to compare to the position control and that posting book. That's when we noticed that there was about 300 position or posting forms that were not in the position book. We couldn't account for them. I don't know where they were. once we noticed that, we just started from ground zero. We reposted every single position in our position control. So every unit then got reposted for the staff who were floating to be able to bid on. Each unit had positions assigned to them that would ensure coverage every day. Every full-time person had a part-time complement, so that 7 days a week would be covered. The staff would bid on the positions. They were awarded based on seniority. Now, each unit had those designated positions, so they were in their orgs for finance.
Excuse me, Dawn, as you're going through, would you specify what page, if you turn the page?
I'm still on 4.
Oh,
I'm
sorry.
just trying to
Okay,
go
no,
through.
That's where I was, I just wanted to be
Yeah,
sure.
I'm just trying to give you a background, and then I have a lot of details to
That's fine,
present.
and if you could just, as you go forward, say page 5, page 6. 'Cause I know
Absolutely.
you have a lot of data here.
Absolutely. So in the staff would bid on positions. Now, each unit had their own designated staff. The same staff, they were able to build relationships with the residents, with their peers. As you know, when you work with somebody you really like, it's so much easier and it's more enjoyable to come in to the work facility. But more importantly is the staff got to know the residents. They got to know their little quirks, their innuendos. What food did they like? What time did they like to get up? What time did they like to take a shower? And things like that. We went from 130 FTEs in the relief org down to 25. We went from 100 FTEs in the staffing org down to 58. I want to just explain that there is a difference between an FTE, which is a full-time equivalent, and a position. A position is considered part-time, full-time, or PRN, which is as needed. An FTE equivalent is the employee's scheduled hours divided by the employer's hours for a full-time week. So when an employer has a work week of 40 hours, employees who are scheduled to work 40 hours would be 1 FTE. If an employee is scheduled to work 20 hours, that's 0.5 FTE. At the time of the reconciliation, we also noted that we had employees that were working, or their FTE was assigned to them as 0.2, which is fair because that's a 1 day a week, which we currently have, which is PRN. However, those PRNs, when we first started, were required to work 1 day every 6 months. The 0.4 would be 2 days a week, yet we would have some that works 1 day a week but receive the part-time benefits because 0.4 is considered part-time. 0.5 should be 20 hours a week, but because we work 8-hour shifts, there was no such thing as a 0.5. No one ever worked 20 hours a week as a schedule. We had a 0.53. We had a couple of those. They were 21.5 hours per week. Again, we didn't have such a position. 0.55 we had, that would be 22 hours a week. We had no such position. 0.6 would be 3 days a week. But again, we only did 1, 2, or 5 days a week. We took the time to rectify these FTEs during that time, so every FTE matched what the person was actually scheduled for and working. We also quickly addressed the folks who are PRN. They were required to work 1 day every 6 months. When all the positions are filled, we would not be able to hire anyone else into those positions. So those folks who were PRN worked 1 day every 6 months. We're kind of blocking it for anybody else to come in. We changed that. We worked with our collective bargaining units, and we changed it so the ASME has to work 4 days per month. One of them has to be a weekend, and one of them has to be one of the major holidays. We worked with the steelworkers, and their requirement is 3 days a month. So those are the RNs. Their requirement is 3 days a month. Again, one has to be a weekend, and one has to be one of the major holidays. Now we'll go on. The next few slides, they will show you the current status, and it's going to get a little confusing, so I will thoroughly explain each one. As I told you when I got here and started to work on position control, there were approximately 500 positions in the book for nursing. In reality, when I went through the HR, we did discover that 322 were unaccounted for, meaning that we had no posting forms, so we couldn't fill them because we didn't know about them. We added those back into the the vacant positions, we added them back into position control. What you will see on the next few slides is the total number of filled and vacant nursing positions. You will notice a large number of vacancies, and there are multiple reasons for this. The most significant reason is the 322 out of the 800 positions that were unaccounted for and vacant when I got here and remain vacant. Additionally, agency staff are not factored into these numbers but we have brought in 4 RN agencies, 41 LPN agencies, and 10 nursing aides. We also are going to be orienting another group of aides, and I believe there's 10 in the next group. So Amy Kaler, who is our right-hand man, pretty much. She is helping me work through that because I don't have a secretary currently. So once we get that, then there'll be a nice timeline. Every other week, there will be agency orientation until we fill our own. And Mr. Heckman, I just hired in the last 2 weeks 6 people, our people. So we are getting there, and our numbers are going up.
6 what?
1 supervisor, 1 RN, 3 LPNs, and 1 aide. So if we can go to slide 5, please. I would like to, again, just denote the difference between positions and FTEs. So to clarify, a position is the status of your employment, full-time, part-time, PRN, and an FTE is the employer's scheduled hours divided by the employer's hours. So when an employee works 40-hour work week, they are scheduled, they will be a 1 FTE. So it's 0.2 for every day of the week, if that makes sense. Do you want me to clarify that more?
Somebody want that clarified more?
Sure. Is employees' scheduled hours divided by the employer's hours for the full-time work week. When an employer has a 40-hour work week, employees who are scheduled to work 40 hours are considered a 1.0 FTE.
I'm just curious, and I know, and this isn't you, because over the years, oftentimes in human services, people's eyes will glaze over. But I mean, is this too much specific? I know you're giving us a lot of data.
I am.
And we often ask for data. But I think that a lot of it, as far as the FTEs go, is, I don't know, do you want as much of detail or more of just, hey, how many do we have? Or is everybody okay so far? No, I mean, when she's breaking down ratios, and I guess I've heard a lot of this for most of my life, and I know I've had people on councils, other councils say, Christ, I don't need to know everything. I just want to.
I can just stick with positions.
I don't know if no, you're not doing anything wrong. You're giving your report, because I have a feeling there might be some questions. So
Sure.
Go ahead.
Sure.
When you say total number of FTEs, you say 1 FTE.
Is a full-time person.
Full-time person. So then you're saying here that there's 533.10
FTEs.
full-time employees
Nope.
working 40 hours a week?
Nope.
Positions.
It,
Can I help you for a second?
please.
So think of it as 1 8-hour workday, a 40-hour work week is 1.0, an 8-hour workday is 0.2, 20% of that.
Yeah, I understand that, but what is 5?
So then 533 full work weeks, and then 0.1 is a 4-hour workday, right? Mathematically?
It's 0.2 each day. Then,
533 40-hour.
no. No, 533 is everything that we do. It's the PRNs, the part-times, the full-times. So it's the 1.0, it's the 0.4, which is part-time, because 0.4 is 2 days a week, every day is 0.2. So 8 plus 8 is 16, which is 0.4. Does that help?
I would stick with the bodies that for the
All right.
ratios you could.
I'll stick with the,
No chart of like equivalency.
you know what, I had one and I left, you didn't print that, did you?
Yeah.
Okay.
And that's why I just brought it up. I mean, I'm familiar with the FTE thing. But if you want to continue, I mean,
will.
go ahead, and we'll get that information to Mr. Rinsky.
I can definitely email that to you. I forgot to print it out, and I apologize. I have it.
Like, you know,
I have it.
like math, like 1 equals.
I have it.
She wants a decoder ring.
I have it.
It's a decoder ring, because when you say
There,
things
that's
to
it.
me,
Here you go.
I've practiced,
There you go.
it's different.
There's a conversion chart.
Just the way that I-
There's a conversion chart. It's coming. But I don't have one for everybody. I apologize.
I think it would be helpful to
This
get
is why I'm a philosopher and not a mathematician.
Okay. I will get those to everybody. Can you just remind me? So for now, I'll stick with the positions, the number of positions. Currently, we have 816 positions only in the nursing department, does not include supervisors, does not include unit clerks, just RNs, CNAs, and LPNs that work on the floor.
Are those approved positions?
Yes, they are.
Number of people. It's approved.
These are approved positions. Yep. So in the admin, which is my risk manager, infection control, we have 44. So in the nursing admin org, we have 44. In the unit clerks, we have 16. RNs, we have 101. Those are positions. That means they're full-time, part-time, and PRN, which I will get into in a little bit. LPNs, we have 198 budgeted, approved positions, and CNAs, we have 457. I'm just going to ignore the FTEs at the moment. Okay, so please note that these are based on a census of 688. Our current census is 400, so in essence, we do not need to fill all of the vacant positions. For example, the 36, we have current status of RN positions. We have 101 positions. Out of that 101, 36 are full-time. We do not need 36 because we have a census of 400. We would only need 16, which is half of our vacancies. So our vacancies are 26. We only need to fill 7 of those to be where we're at or where we need to be. Does that make sense?
Go ahead, Mr. Myers.
So that 7 would put you up with the, what, a point, 4.0, 4.1? Is that how you're gauging this?
No, that's on a 2.7.
On a 2.7?
That's on a 2.7.
You didn't clarify that, that's why I wanted to make sure.
Okay, fair enough.
So, yeah, and I think the point is then, and I think we understand, 36 positions have been approved.
Correct,
Right now, 10 have been filled.
correct.
And 26 are vacant, but if of those vacant, if you
We only
can
need
fill
7.
7, you'll have 17 filled, and that will bring you to
What we need.
what you need.
Yep.
Right. That's pretty much going to be the flow on all.
It is, it is. Again, I'm going to ignore the FTE column. So,
I don't understand.
okay,
Oh, I'm sorry, go ahead, Tara.
I don't understand how you can only have 10 filled positions and 26 vacant and still have enough staff.
because it's based on a 688-bed facility with 16 nursing units open.
Okay. All right.
Okay?
So now, do these vacancies then represent full capacity? Are you intending to get back to full capacity? Yes. That's the intention? And so is there, I guess what I need is like a column that says what's necessary for what we currently have as a census. So-
It's coming, it's coming.
Oh, it's not. See,
Yeah,
at
we-
least I anticipated
have a plan.
something with numbers, okay? This is
It's-
a lot.
I know,
Numbers,
I understand.
a lot. Thanks.
On page 7, on page 7, that is the current status of the LPN positions. Again, this is based on a 688-bed facility, which we do not need all of these positions at the current time filled. The total, we have 198 total LPN positions. 93 of them are full-time. So 39 are currently filled. So there is, again, what we need and what is vacant is different because we're basing it on a 400 census as of right now on a 2.7 PPD. On page 8, it will show you the status of the CNA positions currently. So on page 9, I believe, Ms. Zielinski, is where you're going to get the information you want. This is based on a 400 census with our Tower 10 closed because we are not using it at the moment. So based on 400, which is our current, for a 2.7, if we have 65 RN positions, we only need 32, and that is full-time and part-time. I didn't want to break it down further because I thought that would be too confusing. So
So what we need and what we have are ifs here. If, you're saying if we have 65 and we need 32?
no, I'm saying we do have saying we have 65 positions right now. If we need coverage for a census of 400 and we want to meet a 2.7 PPD, I'm sorry.
We have 65 bodies in that position of RN. And she needs 32 to bring her up to the
2.7, correct.
7 that we're at right now, if we have 400 people.
Correct.
Then what are we eliminating?
She'll get,
If we were only going to stay at 400, I do not need those 33 positions. So if for some reason we don't need that. But again, I'm just basing this right now on what we have.
right now, I think we're eliminating.
Okay, so I got it, 400 census. So we need 32 RNs to meet that 400 census.
Correct, correct. We need 32 part-time and full-time. They're combined,
Now, when you say we have,
correct? We have 65 positions, part-time and full-time, budgeted, approved.
these are the positions.
Right. So if you look at the top, the total number of positions,
So the ones that we need represent the ones that we currently have.
the ones that we need are the ones that need to be filled, part-time and full-time, to meet the 2.7 PPD based on a census of 400.
I'm gonna get a cup of coffee at the break and sort this out. Fine. Awesome, keep going.
Okay.
So anybody down?
Okay. And then again, if we want to get to a 3.4, and then we have, of course, the proposed 4.1 PPD. So those are the numbers that we need. If we do that and we stay at 400, those are the numbers we need, what we have, and what we don't need, which can be eliminated.
So that's, you're projecting.
Correct.
That, you know, this is about 400.
Exactly.
That's it.
Exactly.
And the PPDs are the ratios, and you're saying,
Correct.
okay, we definitely want to try and hit 2.7.
Absolutely.
If we wanted to get to 3.4, these are the.
Correct. Correct. Correct.
We don't pretty much.
Okay. On page 10, this is the state of affairs if we have to go to 1 and 2 bedded rooms. That would mean,
I'm sorry, I just informed, my microphone was off, and I apologize. You guys all set? Okay, we're going to go on to number 10.
page 10.
I forget sometimes that I got to project out to the audience. I'm talking to people up here, but, so we're all clear. But anyway, so now I'm on, we're set.
Page 10.
Yes.
So the current state of affairs, if we had to go to 1 and 2 bedded rooms, we would need 15 units to be open. On page 11, it does break that down for us. So those 15 units, it would tell you how many 1-bedded rooms and how many 2-bedded rooms. That would be for a total census of 404.
All right.
On page 12,
So that's all we could have.
if we go to 1 and 2 bedded rooms.
I totally understood that.
Perfect. Thank you.
You're getting
Page,
started.
page 12,
Go ahead.
page
Page
12. The 1 and 2 bedded room staffing, again, 15-unit census is 404. So if we needed a PPD of 2.7, which is the Department of Health current minimum, those are the positions we'd need 38 part-time and full-time RNs. We have 65, so we would not need 27 of them. That's if they force us to go 1 and 2, but as Jennifer said, we think we'll be grandfathered. I guess we're hopeful we'll be grandfathered. 3.4 is a kind of a compromise from what the DOH currently has to their prediction of 4.1, what they're requiring, they're thinking to go to. So again, that all breaks down there. Is that okay?
I think so. Anybody at this point?
Yes.
Mr. Brown?
Just following your numbers.
Yes.
If on page 9, under the 2.7 PPD, for RN, you have currently 65 positions approved, and that's based on the 400 census of what you would need, or is that based on the?
That's based on 400.
Right, and then on page 6.
Yes,
But that 65 include part-time, full-time, correct?
yes.
But on page 6, you have part-time, full-time RN positions at 67. Am I not following your math correctly?
You are following my math. That's my error. I apologize.
So that should be 67.
It should be 65.
And then
It should be 65. On page 6, I have an error. Right off the bat, we can see I have one extra full-time written there. So then it would go down to 30. For part-time, it should be 30, and the full-time should be 35.
Okay.
So that's my error, Mr. Brown. Thank you for bringing
No,
that
that's
to my
all right. I
attention.
just want to make sure I was following
You were.
your
You
math.
certainly were.
And then also, then following the same logic.
Yep.
Under LPN. You have 164 positions on page 9. You have,
Page 9.
and then your math on page 7, you have 172 full and
Okay,
part-time.
I will have to revisit that, and I apologize for that.
It doesn't change significantly, but.
Yeah.
I understand you're moving through.
Right,
So, okay, I just want to make sure I was
you are,
following your.
you are. Thank you. Thank you for bringing that to my attention.
You need anything else, Mr. Brown?
No, that's good, thank you.
That's why there's 9 of us. Somebody could catch, somebody will catch something.
And that's fine. I will definitely update that.
All right, so I think we left off, you were talking about page 9, or, I'm
Page
sorry.
12.
12 with the 1 or 2 beds. All right, go ahead.
Correct.
Page 12.
So again, that is what we would.
Mr. Zirinsky does not want me to go back any further than page 12. All right, go ahead. You're fine, go ahead.
The 1 and 2 bedded rooms, again, 15 units open. So the 2.7, which is the current requirement, is listed there. 3.4, which we think is going to be the compromise, and then the projected 4.1. So those numbers are listed there. Slide 13, if we have to keep the lower census, the 10 units would be open. So if we filled all the beds in the 10 units that we have open, not opening any other units, so all the current units would stay closed and Tower 10 would stay closed. This is the current capacity of all of our units, which is 460 bed total.
Okay. Right, go ahead. Go ahead.
I think that's what I was anticipating. I mean, you're telling us that if you go to this one bed, that you're going to anticipate only having a 460 census, then you can't get up to 668 again.
If we have to go to 1 and 2, you are correct, but that's what was on the other slide prior.
And what would allow us to go to 668 again?
If they did a waiver.
If we got grandfathered. Oh, because we got grandfathered, okay. But I thought we were
So,
not
you know,
going
we're big at being prudent planners, and this is the work, we are planning for the worst-case scenario, because I have determined that there are 400 or 500 people with Alzheimer's or dementia who only have Medicaid that will need a home. And instead of selling it or turning it into an office building, this is our plan to keep it a nursing home. Even,
so
even at a census of 400.
So at the end of the day, if we had a census of 400 or 440 or even 460, that would be doable
Yes,
if we didn't get that waiver.
yes.
And we would still be able to serve the public, and this is the plan to do it. Okay, great.
And that's what we're planning
all I
for, and I'm sure someone will have a follow-up question about the physical plant. Mr. Amealy, Mr. King, and Mr. Kaisler are working on a proposal to retrofit the facility should we have to go to two-to-a-room. And that will be a future Human Services Committee or Public Works or wherever you want it, meeting.
Good times.
Okay.
Thank you.
Go ahead, Mr. Myers.
And that includes shutting down Tower 10?
I'm sorry, that includes what?
So what are we doing with Tower 10 if we're going to hit the 460?
It's closed at the moment. If we need to use it, we would transfer the residents from here and move them up. It's still a census of 460. We would just take them off their current unit and open it because that's an isolation unit.
Right, it's the COVID unit for the time being.
Correct. Or TB or flu or whatever. But yes, so if somebody that we currently have has the flu, we would just move them up to Tower 10. It's still the same census, just relocating.
All right, that, I just wanted to make sure that Tower 10 is still part of the equation.
Oh, absolutely.
Thank you.
Slide 15.
15.
That if we go to 460.
Yeah,
every-
emphasize.
I got the F, I
Miss-
got it.
No, I mean, just for all of us, though, there's the now, which we want to hit 400.
Correct.
As we are today,
Correct.
to get to that 27. If Harrisburg wants to be a bunch of chuckleheads and create a number that has no resemblance to reality, I'm going to use my own funds to take a bus and take people who can go from Graysdale down there and invade their legislative and Senate committee meetings. I don't think it'll happen. I don't know if the compromise will be the one, because, I mean, I think you'd see a lot of problems if they went to 4.1. It's just, I don't get it, but I get they're trying to do the right thing in a vacuum, and that's part of the problem.
Well, I think there's a lot of nursing organizations that are advocating for the 4.1.
Well, they can, I mean, but I would say hopefully Harrisburg would increase the pay, the mandatory pay for people who are in this profession in the various fields, and to couple that, if they want a higher number for the nurses, then couple that with an incentive for people to do it.
And
But
the
I just wanted to
CMS
point out that we're, and as you finish this up, you have questions, and you've already gotten quite a few. I think it's a good idea. We'll take this. We should take it home then and study it. Any questions, get in touch with these folks. And then the next meeting we have, we'll certainly touch on it and any follow-up questions. So I'm sorry, I didn't mean to interrupt, but I know here's what we want to do today, and here are Mr. McClure referenced the two ifs, if this happens or if
Right.
that happens. All of it geared to trying to keep the place running.
Right. So we have a plan for everything. Whatever comes our way, we have a plan.
Well, remember what Mike Tyson said, everybody has a plan until you get punched in the face.
Okay.
But
Fair
I don't want
We
to, I'm glad you're,
punched in the face.
you're planning, and
Yes.
you got to plan, that's part of your job, I know.
Is there any other questions for me?
Ms., oh, wait, I tell you what, I'm going to let Ms. Hefner ask
ahead,
her
go ahead.
question, and then you can,
Do
maybe
you
you'll
feel
have a
like you're done
follow-up.
with the presentation, or are you just taking quick, because are we on the question page? My question is, why are we using the term if, and not just making the plan to adjust? Like, I appreciate the overview of the comparison, but why aren't we planning to just assume the 4.1 and work toward that goal? Or why aren't we planning to move toward, I mean, you're obviously not going to break down the walls today, but starting to plan toward that staffing level rather than an if-when.
Well, we are. I mean, in that plan before you, we have all those scenarios laid out. It is literally in the plan we handed to you. So I think the second piece of that question you just asked is the physical plant question. And we're working, well, what can we accommodate?
No, let me clarify my question.
Sure.
My question is, instead of saying, well, this is what we have if we could eliminate,
Right.
let's just assume we're going to 4.1 and make it happen. Like you've already articulated that this is what would need to happen. So why aren't we just working toward that? And I see you're going to do it right now at 400. You're going to look at 460, because then 460 is the list that we have.
Right.
And then if we get to 500, and if, those are the ifs that
So in the plan that we handed to you, and I think Don just painstakingly went through, you see that our goal, and Jen's goal, Jen is incredibly optimistic, is to get back to 688. And the number of staff we need is in this plan. And of course, that's what we're trying to do. We're trying to get the home back to a place where we can do 668, but we need to be, we need to be prudent planners. We need to count on the fact that people aren't going to come flocking back to working in long-term care facilities for the foreseeable future. We just have to be realistic about that. And we have to plan for all the various scenarios on the way down to 400. We'd like to be at 688, and in the plan that we handed to you, we show you that. And we'll continue to try and get there through a combination of hiring our own people, which is what we prefer, and agency, which is going to be critical in the short term.
I guess my reaction is coming from the fact that I'm seeing the if and then the we can eliminate. And the point is, we just approved a plan to retain and increase staff.
Right.
So why are, I guess to me,
I get-
getting lost in the data as opposed to why are we not keeping these people? Because wouldn't that increase the number?
Well, so if we get,
To 4.1.
so if CMS changes the guidelines, we don't get grandfathered and we're 2 to a room, 404 is our number. We have to plan for that.
That's my other question. If we don't get grandfathered, then what is the legal capacity of the home?
404,
And that's it?
yeah. But there are 400
Unless there's
people.
expansion
But there are
elsewhere.
400 people in this county every year who have nowhere else to go. And as long as I'm here, they will not die under bridges. That's just the facts.
Well, no one's.
No, I'm not saying that, but I have to plan, for that. And I think you'd fault me in the future if I didn't have a plan for 404.
We're all on the same page. My question was simply, why the if statement and why not act as if? But I hear what you're saying regarding, and what's the likelihood of grandfathering? Has anybody explored that?
I don't know. We don't know. We don't know. That's why we're planning.
So then if we're using the word if, and if we're only at capacity at 404, but we have the potential in the licensing, then would there be a plan for capital expansion? To
Well-
build another piece, or is there another building or facility up there that could be converted to accommodate?
Well, that's what Mr. Mealy, Ms. Stewart King, and Mr. Kaisler are working on as we speak, and they should be done in about a month to come to you with a plan to do the two if we have to, with a price tag.
Of course. Sounds
Somebody-
like fun.
Somebody on a phone?
We all have phones, but
We all-
No,
somebody picked up
I just want to
something.
say,
Sarah whistles. Sarah whistles.
sometimes I say things emotionally, and I know that the nurses, when I say, you said the nurses want to see it, I don't blame them. I mean, they're with the staff, people who are staff who see the people they serve every day. I don't blame them. They see what is needed, and they feel 4.1 would be absolutely needed. I've come in, I guess, having been in management from a manager's position, given what we've heard and what we saw over the pandemic, we'd be in a bind if all of a sudden, as a lot of other places would, if we go to 4.1. That's why I don't dismiss the nurses' concerns or any of them. It's actually the government that I'm concerned with, the state government, because they come up with things, but they don't follow through with what we need to backfill to get to it. So I just wanted to clear that up. My chuckleheads have nothing to do with nurses or, but go ahead. And then Mr.
So I guess, thank you for this comprehensive, multiple scenario plan. I do understand it. What I don't understand is the if-when timeline. Like, when will we know when we could potentially get a waiver? When will we know if we have to go to 4.1? And if we don't know those dates and have a timeline, how can we implement this plan? It seems like a little chaotic.
It's a waiting game. It's CMS, Department of Health made the first announcement they were going to do a 4.1, Pennsylvania Department of Health.
Right.
And then President Biden made a speech that said
Yeah.
they're overhauling everything. So now DOH is waiting to see what CMS is going to say, because you go most by the feds, what the
Right.
feds say.
Right.
So that's why one is waiting for the other one to make a step, but they haven't, because they've had this open period of conversations. And every group, Leading Age, PACA, PACH, are all the long-term care groups, and they're all converging on CMS saying, what are you doing? You're going after the investment nursing homes, but in the meantime, you're killing the county, the state, all of these other ones you're taking down with them. So that's why everybody's kind of just at this waiting game. Nobody can make a move.
So right now, the only move that we can really make is to stay and keep the census low, right?
Correct.
So these if-when scenarios are not going to occur until either the feds or CMS makes some sort of ruling, right?
Right.
So for now, the if-when is delayed in a future unknown time, and all we can really deal with is this census.
Right.
So all these numbers about this is what we need and this is what we eliminate, it's basically we're on page 9, based on a 400 census with Tower 10 closed. This is the scenario that we're dealing with.
Correct.
Okay, good. See, just wanted to clarify.
If they came tomorrow, I mean, I could admit 60, 70 people. I could
'cause
open
they're
2
on a
more
wait
units.
list.
Right, but why do I want to do that if the feds then come back and say, you know, now you got to close because you have too many 4-bedded rooms?
Well, you couldn't, what would you do with the people if they did that? Would they make you find beds for the people that?
No, you'd not be able to admit until your census came down. So why do that and stay at a 400 where we know we can manage?
Okay.
And I think, like we said at a previous meeting, I think we're in a, if we look at like a triage stage.
Right.
We really got to stay at that 400 and have the staff for it, but be prepared like a good scout for possibilities.
Correct.
But right now, I think we're focusing on the 400.
Right.
Mr. Giordano. I'm sorry.
It's all right.
Combine names.
I was posting with former judge and a joke, but I'm sorry, go ahead.
So I'm sure I have plenty of questions, but there's very few answers that you can give me just because you don't. But as far as the PPD is calculated, what employees qualify for PPD hours?
So as of right now, it is just the RN, the LPN, and the CNA on the floors. The hope is when they do change this, and their goal, most states have, is to open it up to everybody else. Your social worker, your dietary aide that sits there with the resident and helps feed them. It's your therapy personnel that go in and actually doing changing
High
and
school students
teaching.
for community service possibly sitting with elderly people?
Absolutely.
The biggest thing that, I feel like everybody wants to see Graysdale do well. It's a county-run nursing home. But at the same time, the people in the county have to be, whether it's volunteering or, taking a pay cut to work in a county. I think that's really the answer, because with these regulations being stiffening, cutting the rooms in half, they're making it near impossible to be successful. So,
And they did this years ago with the assisted livings.
well,
And
hopefully it goes that route, and hopefully we can advocate for that as well.
Thank you.
for you.
I only saw Mr. Goffredo, and sorry, Mr. Giordano, you had to pay for his
Mr.
joke.
Giovanni,
It's
it's not Giordano.
He's a
That's
good guy, never mind. Yeah, he's a lawyer. All right, anybody
lawyer,
else?
yeah, you're right.
Mr. Lott, I'm not confused on numbers now, I'm confused. I mean, I see what you're saying, and I
Good-looking guys,
understand.
both good-looking guys, you know.
Yeah, all
I can see it.
good-looking men.
Now, I almost forgot what I want. Oh, just clarification, the eliminated, the column eliminated, those are positions, not personnel. Right.
Correct.
Just want to make sure, because I keep hearing that are positions on the book.
Correct.
That could be eliminated. That is not employees that could be eliminated.
No.
Just wanted to clarify that.
Yep.
Are there any other questions? Mr. Brown?
I guess for me, the question would be, based on the 400 scenario, you lock in that's going to produce so much income from the beds and the auxiliary income that comes in.
Correct.
What is the P&L, profit and loss, based on the number of employees that you would need, as you highlighted here?
And those
I'm
are,
trying to get a sense, saying, okay, we can generate 30, 35 million. Operating costs are going to be wide. There's going to have to be a supplement.
And
or
those.
not? That's what I'm trying to
Right.
understand.
I don't have that now, and that's something that I work with one of our consultant firms, which is Affinity. They're actually going to present to you at one point. One of their specialties is finance and nursing homes. They help a lot of nursing homes. So we're going over those things as well as our own accounting staff. So we'll have that information for you.
Are there any other questions on this PowerPoint? I mean, I understand, I appreciate the data. I mean, sometimes you can get drowned in data. And I guess, in fairness, since I've been involved with it for so long, I understand where you're coming from, but I could see with this much data, but it does show that you've taken into account the possibilities
Correct.
going forward. Now, and you said, and you answered Ms. Zirinsky, a lot of this depends on people at a higher, I don't want to say
Right.
pay scale, but a higher place. I mean, we're sort of at the end of governmental crack the whip on this deal. I mean, who knows what they plan to do? I'm only hoping that common sense, and just the reality of what the situation
Right.
is plays into it. But thank you. I don't know if anyone has any other questions regarding Graysdale while we have. Did you have more that you wanted to say?
No, I just wanted to let Ms. Fargo Hefner know that the reason for the ifs is to show that we are prepared. We know what we need, when we need it, for what PPD we need it. So that is the reason for the ifs. So that's why that's in this presentation, because I was afraid if I came here without that, you'd be like, well, what happens if you have a 4.1, or what happens? So that's why I presented it that way, and that's why it's already in here, to pre-answer your questions.
Fair point. And at some point, we're going to talk about physical structure, and we can also talk then about finances, as we like what generates, because I know we've talked about this. There's finances, a minimum number you need, and then there's also where it pays sort of for itself, but then
Right.
where do you start getting into county money? And then that becomes a governmental decision, another discussion. I mean, we've all kicked that around in the past. Some people say no, and others say, well, how much would we have to give? So those are, and again, that is, right now I'm focused on 400 and the staff you need to do that so that we're on the raft and we're not going under. And then from there, who knows? The state will let us know, the feds will let us know, and I guess we'll just have to learn to adjust. Anybody that's worked with DPW and the agencies know full well that you better know how to adjust yourself. You'll be in trouble with those agencies. But anyway, so thank you very much.
Welcome.
Good job. And I think we have a little bit of time for Ms. Wondolowski. She wants to give us a report.
Yes, sir. I have a short report, but I have a few things for everybody. Following up on the long-term care, there was a recent article in McKnight's Long-Term Care News. Jen is forever forwarding me great info about person-centered care and behavioral health training as part of a new federal program. So I just wanted to mention that because, as you know, we have Haven House in there pretty much providing this exact service. So we're about 3.5 years ahead of the curve from the feds.
And I didn't ask Jen, Sue.
Sure.
But that's fine, but I would assume, we've covered this, but I would assume we're seeing more and more residents coming in to us that possibly have some of these behavioral health and.
Correct.
And issues along those lines.
Yes.
Dementia, Alzheimer's and so on, which I think is important for us to always keep in mind. I mean, I know people have argued with me for years and said, there's a bed for everybody, and I can't argue with that. Somewhere there's a bed for everybody. I don't know where, but I'm concerned because I don't know how many beds there are for people who have behavioral health issues that quite frankly maybe shouldn't even be in a nursing home, should be dedicated, but they don't exist really. So again, I just was curious because I think that's always important to keep in our minds that when they say, well, you're competing with so-and-so. Not necessarily, not for all the people that we see. We're not competing. I mean, sure,
Correct.
they take Medicaid, but it depends. There's Medicaid and there's Medicaid. But anyway, I'm sorry, I didn't mean to
No,
interrupt
I
you,
was
but
just explaining.
Since you mentioned LTC, I wanted to.
Sure. I was just explaining to somebody last week how they, they don't compare apples to apples, right? They're comparing, county homes are compared and all that data with all the for-profit homes too, and we don't get to cherry pick who we take, and we don't want to. We want to be able to help those folks that no one else will help. But I'm excited that the feds are talking about it, and so in addition to Haven House, there might actually be some federal or state money that's put towards training for staff in behavioral health above and beyond what we're already doing. And one of the things that we're working on adding with the Haven House staff, who are forever open to any new idea we throw them, is also providing support for our staff. I may have mentioned that in the past, but we've identified the person from Haven House who is going to be the point person for our staff, and over time, she's actually gonna do more rounding on the units so that staff become familiar with her and comfortable with her, and they can walk and talk on the fly as, just some brief support. And if they need additional EAP services or counseling services, certainly we would refer folks for that. But it's just, in addition to the director of nursing and the assistant director of nursing, now rounding for at least the past month or so every day on every unit, this person will also participate in that to a lesser degree to become a visible support person. So we're excited for that. And Dawn, I think, mentioned how many folks, or Jen, that we recently hired. We're very fortunate that we've been able to get as many agency staff as we have until we can hire our own staff. But I just wanted to give you the super brief highlights of the recruitment efforts that Graysdale has been doing. Some of the new things, I guess, I'll stick with. We are working with VIA and Goodwill, and specifically for dietary positions, for example. So we have some adults with intellectual disabilities who maybe need a support aid, maybe they don't, and they really work well in our dietary department. And so we've been able to expand some of those services, and we're going to be partnering with, or hopefully partnering with, the Lehigh Valley Center for Independent Living. So we're really trying to explore new and different avenues beyond what we've already done. And our current recruiter at Graysdale has found a lot of new ideas. So we've heard an awful lot about Graysdale tonight, so we could talk about that at some other point, but I just wanted to let you guys know that. I think you hopefully may have seen the press release. I think I talked about this at one point, the warm handoff program. So the Suicide Prevention Task Force and our Mental Health Division has worked successfully with Lehigh Valley Health Network to create a warm handoff program. And I'm just going to read the quick bullet points so that I think it gives an easy explanation. So when someone is admitted from the ER to an inpatient bed at Lehigh Valley Health Network for either suicidal ideation or a suicide attempt, upon discharge, there will be folks from Lehigh Valley who make a direct referral to a point of contact in our mental health division. And the goal is to be able to assist those folks with locating recommended services and navigating the referral process, assistance with understanding insurance and how to access services through it, linkage to peer and community supports in the county, and linkage to any other Northampton County services if needed. And the goal is to provide, for our mental health department, to provide initial check-in when the person is discharged from the hospital, and then subsequent follow-up for a few months to ensure that that person is able to access services and provide any assistance that's needed. So Tiff Crush, who is our assistant, or our administrator for mental health, worked probably for about 2 years just to create that whole concept, and Lehigh Valley has been a wonderful partner on that. We're working on St. Luke's, but hitting some roadblocks, so they may already have something similar, so stay tuned for more on that. May is Older Adult Mental Health Month, so you may have seen a short letter to the editor by Lori Grieco talking about mental health and our older adults. So stay tuned for some events perhaps this month that get posted on the Facebook page. Robin Barbosa, you know, my fantastic deputy. One of the things she does is chair our employee enrichment committee. And so every month we honor, there's on the calendar, we're honoring somebody, right? So May was National Military Appreciation Month. I think it was Pacific and Islander Month. This month is Pride Month. And so Robin has done a great job sending emails out. Black History Month, we do things to the group to try to engage our staff in not just sharing information, but really trying to engage them. So I think she's done a really great job on that, and it's been really neat for Military Appreciation Month. Folks were able, if they're veterans, to submit photos and short bios to Robin, and then with their blessing, she disseminated them to all of Human Services. And so it's just been a neat way to try to get connected to each other in the Human Services building. So I appreciate that. And I think that's about it, Mr. Heckman. I'm trying to keep it short for you.
All right, we're going to open it up to questions. By the way, at PBS, I know they repeat things a lot. One of them, there's a great hour-long documentary. It's on our national mental health situation and how we are just not doing a very good job at all with mental health. And it talks about prisons and nursing homes and just in general where we're at. And it's sad to watch, but it is what it is. Questions for the director for anything regarding Human Services?
Mr. Heckman, I forgot one of really probably the highlight of my report. We just had a former aide at Graysdale, Peter LeBlanc, who utilized our tuition assistance program, and he is an RN, and he was just slotted into a day shift position at Graysdale. So I know folks have asked how that is going, and we're really excited and certainly very proud to have had that success. So now I'm ready for questions.
I'm glad. That's what we do. It's
Yep.
county government service. Ms. Vargo Hefner.
The
ORLTSR.
that,
They're still slating for this month. I don't know if the windows came in. So I did forget to ask that before tonight, sorry.
and I read an interesting article that prompts me to ask this next question, that we hired the consultant from New Zealand, and there was just an article about maybe these bias trainings aren't
Yep.
really effective, so it was kind of like,
Yes.
so I just wondered how we are progressing with our program and what you thought of that article.
Yeah, there have been a few interesting of late, and I suspect that there will be more to come. I actually just spoke with Rima and her team, and we're going to have a follow-up meeting. They have already been working on draft responses to that, if you will. It's not that I don't have concerns. I think we all have concerns, and that's why we're doing this, is to try to reduce racial bias. So we're talking about the project in child welfare, the predictive risk model that we are working on building. And so that when that finishes going through testing over the summer, we certainly expect it to say one thing, but that will be analyzed regularly to ensure that the tool is doing what it's supposed to do. The other thing that we are doing that not all of the other groups have done is engaging with family members who are either currently involved in children and youth or who have closed cases with children and youth. And our first, I think we're just calling them family engagement meetings, our first one is scheduled for the end of this month. And we have someone who we have worked with on our advisory board in the past, and he's run our Act 33 meetings, and is a very good facilitator, and he's a former kinship foster parent and a pastor. So he's going to help us facilitate that meeting. So in fact, invitations just went out to about 40 families yesterday, and then we will follow up with those folks to try to get a small group to come. And basically, the primary purpose of that is to engage families to find out, what do you wish had happened differently in your experience with child welfare? Was there anything that worked for you? What would you like your caseworker to have said to you? How would you have liked them to support you better from the beginning? so on and so forth. And initially, the idea was to do 1 or 2 of those, but I told our New Zealand team and the county executive, I'm committed to doing those maybe, 3 times a year, quarterly, on an ongoing basis, because I think that's really important information. And so I think one of our big thoughts is that the transparency of the process that we are engaging in, and engaging with those family members in particular, negates a lot of what you are reading and will continue to read.
Because it seemed to be highlighting the Allegheny program as, not
It does talk about
ours.
that one, yes.
So, God,
Correct.
I don't really know specifically what
Correct.
happened or did not happen.
And the consultants who are working with us have not worked with all of the other models that you will be reading articles about. And some of them probably they shouldn't use. But that's why we chose Rima and her team, because they're academics and they're scholars and researchers. And the Allegheny model, after it was implemented, also went through an ethics review with, I forget what universities did it. And so we will be doing the same thing in some capacity basically to ensure exactly what you're talking about, that we're not taking the racial bias in the wrong direction.
It's just a hard task to begin with. So I mean, I do appreciate all the efforts, and I, just wondered what
Sure.
you thought or what your responses internally were to that. And my last but not least is, I don't think we've asked this in a long time. Civil
Service.
We,
Well, there's something on the agenda for tonight's meeting that may be helpful to our cause.
what is it that I have this vibe and I always blow it before you?
It's okay. Maybe you saw the agenda, I don't know.
Well, maybe. I didn't mean to do it that way. I really am literally just sitting here thinking what we haven't talked about in a while and haven't asked about, because
Sure.
it just always seems like wait and see, so.
So the last piece of the puzzle that we were waiting on, as you all probably recall, to get out of civil service, is a current contract with PSSU. They voted on the contract a week or 2 ago. They voted to accept the contract. That will be on your agenda for tonight. I'll let the county executive tell you about that. Once that is all signed, sealed, and delivered, we will be sending that to civil service. It couldn't come soon enough. They've done some internal changes, and they've made our lives, they are trying to improve. Unfortunately, it's become more of a mess than it was, which is, they're working on it. I don't fault them. It just is, we will be better off when we can be out.
Thank you.
Other questions? Office space. You brought that up a while back.
Yes, I
The
did.
building that you were getting a bit crunched. Where are you at now with that?
We are no less crunched. We are more crunched. I think the county executive had talked about, at some point, if there's additional space in the county to shift some of our non-DHS folks who are in that building out, that will give us a little more space and probably just enough space. But for now, we have been exceptionally creative, and I think we've turned one of our last storage rooms into 3 cubicles. So
Okay.
we're making do.
I mean, and that's not unusual. We build it for something and I remember we talked about like the parking deck, you couldn't go up, it was never made. Was this building, I don't even remember, I'll have to ask Mike if it's made so that you could actually put another floor on top?
You cannot, I asked pretty much after I got here and was told, no, it is zoned for 3 stories. There's no room
That's the
to go up.
industrial- That's the zoning there, 3 stories.
Correct.
Okay, all right.
Because there's no room to go out, I was hoping to
Yeah.
go up, that was a no.
Okay, if there's no other questions, we've had quite a long meeting. Thank you. And
Thank you.
Mr. Kusick, your absence was noted because Ms. Zirinsky had a lot of numbers questions, and I think she missed you being here. But anyway, okay, meeting's adjourned. Do I have a motion? Please make it. All right, motion's made. We're adjourned. Thank you. Bye.
I was like,
I said the fun was for me.
thank you.
Of course.
I appreciate it.
Anytime.
Have a good night.
Am I just like collecting them, like keeping them like saved on my computer, or do you want me to send them?
You can send them to me and I'll save them where I save them.
Okay.
So, but I want to talk to him about how he wants them edited, because then we can, like, for